Good afternoon. My name is John Iskander, and it's my pleasure to welcome you to the August 2012 session of CDC Public Health Grand Rounds on high-impact HIV prevention. We have a number of fascinating and important Grand Round sessions after today's sessions as well to look forward to this fall. For information about all upcoming topics, please consult the Public Health Grand Rounds website. Continuing education credits for Public Health Grand Rounds continue to be available for multiple professional disciplines. Details are available through the website listed here, as well as the previously listed Grand Rounds web address. We've partnered once again with Science Clips and the CDC Public Health Library and Information Center to feature scientific articles relevant to HIV/AIDS prevention. This month's selections, made by CDC subject matter experts Laura Fairs, Irene Hall, and Stephanie Sansom, delve more deeply into aspects of HIV/AIDS, including economics, estimated HIV incidence, care and treatment, and the future of HIV prevention in the United States. These are available at cdc.gov/scienceclips. Today's speakers include Dr. Jonathan Merman, Dr. Irene Hall, Dr. Stephanie Sansom, and Dr. Grant Colfax. We're especially pleased to welcome Dr. Colfax, who is the White House Director of the Office of National AIDS Policy. Before we begin our session, it's now my pleasure to introduce some pre-recorded remarks by the CDC Director, Dr. Thomas Frieden.
HIV remains the most serious infectious disease threat facing the U.S. and the world. Although there's been enormous progress in the past 30 years, we have much further to go, and we now face the risk of deadly complacency. More than 1 million Americans are living with HIV, and 50,000 or so more become infected each year. Men who have sex with men are 40 times more likely to have HIV than other men, and there has been an alarming increase in HIV infection among young black men who have sex with men. Far too few Americans with HIV have their virus under control. Viral load suppression needs to be the fundamental indicator for both clinicians and communities. High-impact prevention aligns with the National HIV/AIDS strategy and provides resources where they're needed most, for people at highest risk, and for interventions that are proven to work and to be scalable. It's important that we achieve an AIDS-free generation, that we ensure that people are tested for HIV, that those who are positive are linked to care, that care is effective and results in viral load suppression. High-impact prevention with rigorous analysis and continuous improvement will help us ensure that the precious resources we devote address this devastating pandemic as effectively as possible. Thank you.
It's now my pleasure to introduce our first speaker, Dr. Jonathan Merman.
Thank you, John, and much appreciation to you and Tanya Popovic for helping improve all of the presentations that you'll hear today. Today I'm going to discuss using science and good sense for optimizing HIV prevention and show some examples of how CDC has put theory into practice. The HIV epidemic in the U.S. is growing. Today, over 1.1 million people are living with HIV in the country, and the number of persons with HIV, shown in red, has increased 60% in the past 15 years. Each year, there are about 50,000 new infections and about 20,000 deaths among people with HIV, a net increase of 30,000 people living with HIV each year. This is good news since it reflects improved care. However, it also presents a challenge for prevention as a stable incidence, shown in blue and yellow, and effective treatment result in an increasing number of people with the potential to transmit HIV. In addition, HIV is a quintessential issue of health inequity. African Americans are 8 times more likely, and Latinos are 3 times more likely to be diagnosed with HIV than whites. These disparities are highlighted among women. For example, The number of women estimated to be diagnosed with HIV in her lifetime ranges from about 1 in 32 African American women to 1 in 500 white or Asian women. HIV prevalence is also associated with population density, region of residence, poverty, education, unemployment, and homelessness. In addition, men who have sex with men are more than 40 times more likely to have HIV than other men and women. The magnitude of the impact of HIV for gay and bisexual men is illustrated in this figure. It shows the estimated lifetime risk of acquiring HIV among MSM. If current trends continue, half of today's black MSM will have HIV by the age of 35 years, and for MSM overall, half will have HIV by the age of 50. And the model data presented here are a clarion call for rapid effort. The first line in orange represents the current situation in the United States, where the stable incidence in 10 years would result in an additional 550,000 infections. The blue line shows that if we reduce incidence by 25% over 10 years, we would prevent 62,000 infections and save the US healthcare system $23 billion. But if we meet the 25% goal over 5 years, as shown in green, then we would save 109,000 infections and $42 billion. So faster action now saves lives and resources later. There's an urgent need to improve efforts. Here are some specific HIV prevention interventions categorized by those focused on people with HIV to reduce transmission, those focused on people without HIV to reduce acquisition, and a few not focused on HIV status. Some of these have shown substantial efficacy. For example, taking daily antiretroviral therapy by people without HIV reduced acquisition by up to 73%. Taking daily antiretroviral therapy by people with HIV reduced transmission by 96%. Voluntary male circumcision was associated with a 60% reduction in HIV acquisition, and over 70 randomized controlled trials have associated behavioral interventions with reductions in risk behavior or sexually transmitted diseases. Given a growing epidemic, a plethora of potential interventions, and constricting resources, how can we reach our prevention goals? Several years ago, the concept of combination prevention was developed to embrace multiple disciplines and approaches. It changed the way we conceptualized HIV prevention. However, we need more, because just combining interventions is not enough. All interventions are not effective, and all effective interventions are not equal. We need to apply the science of implementation to choosing, mixing, and maximizing impact. And that brings up the concept of high-impact prevention, a framework for maximizing the effect that we have on the HIV epidemic. For each potential intervention, we need to assess its efficacy from randomized controlled trials or structured studies, and ideally its effectiveness in uncontrolled, real-life circumstances, which could be different. For example, for condoms, the best-case scenario for efficacy is 94% reduction in acquisition of HIV, but its user effectiveness rate is about 80%. It's necessary to consider economics. Since we have limited resources, maximizing prevention means achieving the lowest cost per infection averted or quality-adjusted life year saved. We should determine the feasibility of full-scale implementation, since interventions need to be at a sufficient scale. For example, a trial of 5 two-hour behavioral counseling sessions among African American women increased condom use, but the number needed to reach is in several million. We should develop epidemic models to project the impact of interventions together, as Dr. Sansom will discuss later. For example, implementing CDC's testing guidelines combined with expanded ART would conservatively prevent 17% of new infections at $21,000 per quality-adjusted life year saved. And based on all of these analyses, we should prioritize the interventions that will have the greatest impact and implement and evaluate these programs. So increasingly, the way we do this is to merge the goals of clinical medicine and public health. Clinical care tends to focus on the inner circles, patients prescribed ART or receiving regular care. Public health focuses on the outer circles, all people with HIV, and we need to increase the scope of responsibility for all parties. And if one of our major goals is to achieve a suppressed viral load for all people with HIV, because that benefits their health and reduces transmission risk, then we need to see the importance of viral load as both a clinical indicator and a major focus of surveillance and public health action, something Dr. Hall will discuss further, as only 25% of people with HIV are estimated to have a suppressed viral load in the United States. Public health agencies, officials, and systems have a responsibility to close gaps in HIV care and prevention services. Recent HHS guidelines recommend ART for all people with HIV, regardless of immune status. Yet only a quarter of people have suppressed virus. On the individual level, lower viral load reduces morbidity and mortality for people living with HIV and provides them with the knowledge that they are less likely to spread HIV to others. On the population level, lower viral loads will lead to fewer new infections in communities. We can emulate successful programs in other disease areas. For example, in New York City, when a patient with diabetes has his or her hemoglobin A1C level checked to assess the prior 2 to 3 months of glucose control, the results are sent to a health department registry, and the registry provides feedback to patients and to providers to assist in identifying patients with poorly controlled blood glucose levels who are at a higher risk of complications. And here we have some examples of success. The primary one being San Francisco, where between 2004 and 2008, the estimated incidence of HIV decreased from 935 infections to 621 annually, as shown in the red triangles. And we see concomitant declines in HIV diagnoses and mean viral load in the community. And this is a remarkable feat. In the US, we have an increasing epidemic among MSM, but the HIV prevention leadership, who was Dr. Colfax until he took over as director of the White House Office of National AIDS Policy, and the safer sex enthusiastic population of San Francisco have shown a consistent decline in HIV incidence in an epidemic predominantly affecting men who have sex with men. An example on a national basis is CDC's new Health Department prevention funding announcement that aligned funding with the epidemic by providing $339 million annually to states and territories based on HIV prevalence. This changed funding allocations, and as can be seen in the orange map of resource distribution, it now matches the blue map of HIV prevalence. The funding announcement allows flexibility based on local epidemic modeling and need, but requires that 75% of each jurisdiction's budget is spent on 4 key strategies: HIV testing, prevention with positives, which includes ART, structural and policy initiatives, and condom distribution. Another program is increasing HIV testing and linkage to care. In the first 3 years of our expanded testing initiative, in which 2.8 million tests were conducted, 18,000 people were newly diagnosed with HIV, 70% of whom were African American and 12% Latino. And it was estimated that about 3,400 HIV infections were averted, with return of about $2 for every dollar invested. And one of our more recent efforts is a series of demonstration projects focused on state-level projects for care and prevention. It involves $14.5 million annually over 3 years for 6 to 9 states to improve diagnosis, linkage to care, retention, ART provision, viral suppression, and behavioral prevention using individual and community-level surveillance data. States will provide information to patients and clinicians about their success along the continuum of care, including when patients have fallen out of care or their viral load is not suppressed, to improve outcomes. And this monitoring feedback loop offers great potential for national activities. We have a growing number of, in conclusion, we have a growing number of people with HIV and a restricted budget that require high-impact strategies. We need to act swiftly because the window for success may be closing, with the transmission rate needing to be lowered every year just to keep the number of new infections stable, let alone meet prevention targets. There are large disparities, and that requires a conscious application of health equity approaches. And to do that well, we'll need to integrate public health prevention, care, and surveillance programs for HIV, as it truly is the best opportunity we have for achieving an AIDS-free America. Thank you. So it's now my pleasure to introduce Dr. Irene Hall, who's the chief of the case surveillance branch at CDC.
Good afternoon. I will describe how we can use surveillance data for public health action. These are exciting times for HIV surveillance. Information about persons diagnosed with HIV is reported to state and local health departments by testing facilities and care providers. Laboratories are also required to report HIV-related test results. Reporting CD4 and viral load test results has allowed HIV surveillance to move from a system with a few sentinel events, such as diagnoses and deaths, to continuous data collection. Now we can assess critical care indicators and endpoints such as viral suppression. This offers new opportunities for public health practice on the population and on the individual level. You will hear in detail from Dr. Colfax about the National HIV/AIDS Strategy. It was released in 2010 and provides a new framework for monitoring HIV. Its main goals are to reduce the number of people who become infected with HIV, increase access to care, and optimize health outcomes for people living with HIV, and to reduce HIV-related health disparities. And here is where surveillance comes in. Many of the indicators of need and outcomes for prevention efforts in the strategy can be monitored using HIV surveillance data. The most important indicators are incidence and prevalence, including those unaware of their infection. They are especially critical as they disproportionately transmit HIV. Knowing their numbers for targeted testing is the first step in prevention efforts. As treatment improves and the number of people with HIV rises, another measure of success is to reduce the transmission rate, the number of persons newly infected with HIV per 100 persons living with HIV. And the other three indicators are linkage to care, retention in care, and viral load suppression. HIV incidence is a relatively new addition to HIV surveillance, with the first estimate released in 2008 and the first 4-year trend released in 2011. It has been made possible because of advances in laboratory technologies. Persons diagnosed with HIV may have been infected for many years. We now have a test in the surveillance protocol that can distinguish recent from long-term infections on the population level. Incidence estimates are based on the number of recent infections and additional information on testing among persons diagnosed with HIV. Based on the number of recent infections, we estimate overall incidence in the United States and by subgroups. About 50,000 persons are newly infected with HIV each year, and we see that HIV disproportionately affects people of color compared to whites. The National HIV Strategy specifically calls for intensified HIV prevention efforts in communities where HIV is most heavily concentrated. Surveillance data can point to geographic areas with high transmission potential and need for intervention on various levels, such as state, county, city, or census tract, to target high-impact prevention efforts. Here are the HIV diagnosis rates in 46 states and 5 US dependent areas. And it gives a clear picture of the unequal distribution of the burden of HIV, with highest burden states in the Northeast, South, and West. We also know that HIV is more common in urban than rural areas. Here are two new indicators we're monitoring: the percentage of persons living with HIV who are undiagnosed and the HIV transmission rate. The left axis shows the number of persons living with HIV, overall indicated by the height of the bar. In light blue, the persons aware of their infection, and in purple, the number unaware of their infection. Since the mid-1980s, the percentage of persons unaware of their infection has declined to about 20% in recent years. On the right axis is the transmission rate per 100 persons living with HIV. Since 1985, the transmission rate has decreased substantially from 31 persons newly infected per 100 people living with HIV to less than 5 in recent years. So this is very exciting. With complete reporting of all CD4 and viral load test results, surveillance can now provide information on care and treatment outcomes. Monitoring the continuum of care on the national as well as on the local level can help determine weak links in the efforts to control HIV. For example, while linkage to care after HIV diagnosis is relatively high, at about 66%, only about 37% of people living with HIV are in continuous care. This continuum of services is the prerequisite for viral load suppression to improve survival and reduce transmission. However, only 25% of persons infected with HIV have a suppressed viral load. Aggregate data can be used for prevention planning, resource allocation, and outcome evaluation on various geographic levels. Individual level data can be used to determine whether people are in care and whether they have a suppressed viral load. This information can be used to alert providers to engage or re-engage people in care, or by health departments by directly contacting patients to assure that they receive the services they need. Maintaining personally identifiable data and these follow-up activities require careful planning, including protocols for confidential data sharing, seeking input from the community and care providers, and evaluation. In summary, surveillance today has become a continuous data collection system that provides data for public health action on provider and individual levels. New data collection efforts and statistical methodologies allow targeting efforts of high-impact prevention and monitoring of key outcome indicators of the national HIV/AIDS strategy. Our next speaker is Dr. Stephanie Sansom.
Thanks, Irene. Good afternoon. I'm going to talk about modeling to identify the optimal allocation of HIV prevention resources in a city health department. This is a project that has benefited greatly from the talented leadership of our Prevention Effectiveness Fellow, Fong Lin, as well as that of Coleman Terrell and his colleagues at the Philadelphia Health Department. Resource allocation modeling helps state and local health departments identify high-impact prevention strategies by showing how to divide scarce prevention dollars in a way that achieves the most impact at the least cost. In 2011 through 2012, CDC worked with the Philadelphia Health Department to model the optimal combination of HIV prevention programs. Simultaneously, we sought to develop a tool that other local health departments might use. Our resource allocation model projects the expected number of new HIV cases over 1 to 5 years. It indicates the best allocation of an HIV prevention budget for each program and population to prevent the most new cases of HIV. The model incorporates the annual HIV prevention budget, $12 million in Philadelphia's case, the size and characteristics of populations with or at risk for HIV, the proportions of those populations that can be reached annually by each intervention, and characteristics of those interventions, including cost, efficacy, and duration of effect. Central to the model is the calculation of the reduced likelihood of an HIV infection following receipt of an intervention. This calculation is based on an individual's number and type of HIV exposures, either through unprotected sex or needle sharing, as well as HIV prevalence among partners, the likelihood of transmission with each exposure, and the efficacy of interventions in preventing HIV. To calculate for each intervention the cost per HIV infection averted, we divided the cost of providing the intervention by the reduced likelihood of infection. The inclusion criteria for the interventions we used in the model were those that aligned with the principles of high-impact HIV prevention and were required under CDC funding to cities with high HIV prevalence, that targeted populations generating the greatest number of new infections, and that were supported by the strongest scientific evidence on efficacy in reducing infection rates. We used a subset of the interventions that Dr. Merman presented. They're shown in purple and include HIV testing, linkage to care and prevention services, antiretroviral therapy with retention in care and adherence to therapy, services to test the partners of those recently diagnosed with HIV, and behavioral risk reduction programs for those who are both HIV positive and for those who are HIV negative. To use the model, we first needed to understand Philadelphia's HIV epidemic profile. From surveillance data, we estimated that Philadelphia has about 245,000 heterosexuals at high risk of acquiring HIV, 41,000 intravenous drug users, and almost 38,000 men who have sex with men. As you can also see, men who have sex with men comprise 48% of new diagnoses. Here are our modeling results of cost per infection averted for each prevention, intervention, and risk group. On the top are interventions typically delivered to all. On the bottom are interventions typically targeted by risk group. Testing of men who have sex with men in non-clinical settings, such as from mobile vans, ranked number 1 at about $18,000. Behavioral interventions for uninfected heterosexuals at high risk of infection ranked last, costing more than $15 million per case averted. Note that testing, care, and treatment interventions tended to rank higher than behavioral interventions. Given HIV lifetime treatment cost of $391,000, many of these interventions are cost-saving. This table shows how the model allocates Philadelphia's $12 million budget to each intervention and population to prevent the most new cases of HIV. The model allocates 39% to testing in clinical settings, 32% to retaining HIV-infected individuals in care, and 7% to promoting treatment adherence. In addition, the model suggests that 21% of funds go to testing in non-clinical settings, of which 13% is for intravenous drug users and 8% for men who have sex with men. Note that some of the interventions are not funded. I'll show you what happens as the budget increases. If Philadelphia's HIV prevention budget approximately doubled to $25 million, most of the interventions related to testing, care, and treatment would be funded, as well as some behavioral interventions. If Philadelphia's budget quadrupled to $50 million, all interventions would be funded. Note that increasing the total budget does not proportionately increase the estimated number of HIV cases prevented. When the budget doubled from $12 million to $25 million, the number of new infections prevented increased from 74 a year to 121, a 65% increase. When the budget doubled again to $50 million, the number of new HIV cases prevented increased from 121 to 126, a 4% increase. One reason is that the model spent as much money as it could on interventions that prevented the most new cases with the least funding. As funding increased, the model put additional money into programs that cost more but achieved less. Philadelphia used the results of this model to inform its HIV prevention funding decisions. It spent more to test men who have sex with men in non-clinical settings, and more on behavioral risk reduction programs for HIV-infected persons, particularly men who have sex with men. It spent less on behavioral risk reduction programs for the uninfected, including no spending on high-risk heterosexuals. Models have limitations. They often rely on uncertain data, and they require assumptions. It's important to test the effect of different data inputs and assumptions. We also should try to compare the outcomes projected by models against real-world data. Models may not incorporate important elements. Though good at capturing efficiency, they may shortchange equity. They may not incorporate all the political or practical barriers to program implementation. They may not adequately reflect synergies among interventions. They support but do not replace sound judgment. Despite their limitations, models can synthesize data from many sources, including local data, and they can summarize complex issues in a transparent way. They can provide a single methodology for comparing diverse interventions. In those ways, models can illuminate planning and programmatic decisions. CDC continues to refine this and other models for the benefit of local and national planning. And now I'm pleased to introduce our next speaker, Dr. Colfax, the Director of the Office of the National AIDS Policy.
Well, good afternoon, everybody. So this is kind of reminding me of one of those Olympic team relays, and I was told by the organizers that unless I end on time, we don't get a medal. So I will try to continue to move things forward. And I think that the team relay is really, the relay is a really good analogy because it really is going to take a team effort to end HIV, both in this country and abroad. I just want to thank the CDC for inviting me and acknowledge Dr. Frieden, Dr. Fenton, Dr. Merman, and their team's leadership in moving forward the National HIV/AIDS strategy. And it's a particularly exciting time at the Office of National AIDS Policy, or ONAP. Our charge is really to oversee the policy aspects of implementation of the National HIV/AIDS strategy, the President's vision. And we're at a transformative time in the HIV epidemic. We have the tools to end the epidemic. We know what to do. And I think one of the things that's really compelling about the recent International AIDS conference that was here just in July is that the focus has really changed from talking about solely how to treat the disease to how to end the epidemic and move forward towards an AIDS-free generation. So it's really very exciting to be here today, and thank you for that, for the invitation. Whoops. Now my medal's in risk because, there we go. Nope, backwards. There we go. Okay. So as Dr. Hall mentioned, the President Obama issued the first comprehensive national HIV/AIDS strategy. And just to put that in perspective, 30 years into the epidemic, until 2 years ago, we had no comprehensive national HIV/AIDS strategy. We had no federal blueprint, no national blueprint for moving forward. And as part of his priorities, the President asked the Office of National AIDS Policy to gather key stakeholder input, look at the science and evidence, and move forward and issue a national policy. And one of the key things of the policy, it has really focused and I think achievable health targets for 2015. And the targets really include reducing the number of new HIV infections, increasing access to care and improving health outcomes for people living with HIV, and very importantly, reducing HIV-related health disparities, particularly among communities of color and gay men, where, as you heard, the epidemic continues to be concentrated in the United States. And the administration and the President's leadership has really invested in moving forward so that we can achieve the goals of the strategy. In the President's 2013 budget, there's over $22 billion allocated for domestic HIV-related activities. And even in these fiscally challenging times, there have been increases, including in the 2013 budget. And really focusing, reinforcing the importance of providing treatment, life-saving and life-extending treatment to people living with HIV in this country. There's $1 billion allocated for the AIDS drug assistance program so that people who don't otherwise have access to medications can gain access to treatment. So how do we reach the national strategy goals, and how are we going to do this? There are a lot of things we can do. There are a lot of possibilities. There are lots of roads to go down. And I think that if we look at what we've learned in the past 30 years, if we look at the data, if we follow the science and bring in the wisdom, the collective wisdom of community, we can really make a difference. And some of the key principles that at ONAP we're reinforcing as we move forward at both the federal, state, and local level is prioritizing health outcomes. And rather than thinking of every possible health outcome under the sun that we could measure, which would be nice, but we don't have the capacity to do that, and it might not be the best use of resources, that we concentrate on a few key metrics, that we make smarter investments in what we're doing, that we target populations most at risk for HIV, and that we focus on evidence-based interventions. Again, there are lots of things that may seem like good ideas, and a lot of things have been tested, and 30 years later, we know a lot of things that work, and we know even more things that don't work. So let's concentrate on the things that we know are actually effective. A shared responsibility. The national strategy was issued by the administration, and it's the strategy for the United States. This transcends certainly at the federal level, we're committed to moving forward and coordinating efforts, but this is a shared responsibility with states, with local partners, nonprofit, and corporate partners. So this is really a strategy that all of us as Americans, as people who live in the United States, are really invested in and committed to moving forward. So how do we bring that sense of shared responsibility moving forward to reach the strategy goals, and beyond 2015 to move towards an AIDS-free generation in this country? Accountability, scale up what's working, and I think when you look at some of the models that have been presented, if we use that information to implement on-the-ground interventions and they actually work, let's scale that up. Let's look at what's working locally in certain jurisdictions, scale them up, and also have the ability to be adaptable and flexible. So we can't take a cookie-cutter approach to the epidemic. All epidemics are local. So the question is, how do we use the data and the science that we have to be flexible but still apply the principles of science and evidence basis as we move forward? The courage to change what's not working. How do you actually say, okay, this is no longer the way to go. We have the evidence that this is not working. How do you actually end things? And that's a conversation that we had at the local level when I was a local implementer. I think it's something that we continue to need to have at the federal and state level as well. And emphasize effectiveness and cost savings. So at the end of the day, how many people are you reaching? And I think the key salient questions here are, how many HIV infections are you preventing? How many diagnoses are you making? And how many people living with HIV are you reaching and suppressing their viral load? Those are the three key questions, I think, in terms of effectiveness. And we know that these lead down the road to cost savings. So just to acknowledge, in terms of making smarter investments, that the CD, and you saw this slide earlier through Dr. Merman's presentation, but I think this is really an important thing to reinforce, that when we make smarter investments at the federal level, the CDC has really been a leader in doing this. And you'll notice that that these maps are equally shaded even though they're different colors, and that's completely intentional here, because what it really shows is how the CDC is in the process of reallocating HIV prevention resources so it reflects the distribution of living HIV cases in the United States. So the blue, the map that's in various shades of blue shows the proportion of Americans living with an HIV diagnosis in 2008. And the orange map shows how HIV prevention funding through CDC's grant-making process will be distributed. So the point here is that this is an equitable approach. This is an attempt to address the disparities in HIV that we see in the United States. That where you have darker shading, that means not only more HIV cases, but it means that more prevention resources are going to those jurisdictions. So a really important piece, and very much aligned with the President's vision of concentrating resources where the epidemic is most concentrated. And I think the high-impact prevention approach is also very, very salient to this. And this is something that we're going to continue to work on in terms of implementation at the ground level of the national strategy. While we know what interventions are effective, there's lots of different questions, and I think the modeling piece that Dr. Sansom reviewed is really critically important here. What's the optimal combination of interventions? And that's certainly going to depend, again, on the demographics of your epidemic at your local jurisdiction, in terms of what kind of social, cultural structures are present in that jurisdiction. So what are the optimal combination of interventions? What are the metrics necessary to measure local program success? And are resources being used by the populations at greatest risk? So it's one thing to say you're allocating resources to reach the target populations. It's a somewhat different question, and actually the next question is, okay, now that you've allocated and you're in theory reaching those populations, are you actually doing that? And then are you actually having an effect? And are the interventions evidence-based, scalable, sustainable, and effective? And I think Dr. Merman referred to this earlier. You can invest a lot of resources in one intervention and have a significant effect in a small population. But over time, the question is, can you sustain that locally? Are you actually having a population-level impact? And how do you sustain that over time? And these are I think, the questions that we need to really be asking with our partners at the local level, with continued community engagement, with academic partners at the local level, to really say, 2 years into the strategy, how do we get this right? And what's changed in the last couple of years since the strategy was released was the emphasis that treatment is prevention, and that treatment really is a win-win-win situation here. There's strong evidence now that earlier treatment is better. And in fact, Health and Human Services and the International AIDS Society guidelines have just recently changed this year to recommend treatment for everybody living with HIV regardless of immune status. So a shift in our thinking, earlier treatment is better for the individual. Data show that treatment of the individual reduces HIV transmission to partners, and some studies have shown a reduction by as much as 96%. Now, very important that that's in the setting of safer sex, counseling, and condom use. So in the combination of a comprehensive prevention approach, treatment has a significant and dramatic additional benefit. And then we know that treating people earlier in preventing new infections is cost effective. So really, the game changer has been treatment. It's a win-win-win for the individual, for the community, and for the nation. So I want to point out to one of the CDC models that has been examined in New York City, and this was looking at increasing HIV testing and treatment to achieve the strategy goals among men who have sex with men who live in New York City. And what the investigators did with this model was examine over time, so that's the x-axis, over time, what would happen to new HIV infections among men who have sex with men on the y-axis if you implemented a number of testing and treatment combination interventions. So the first line that you see on the top, the darker blue horizontal line, is if you did nothing at all, if you sustained where New York City is now. So in that situation, you really get to the point where this country has been for the last decade, which is an endemic state, where there's no change in new HIV infections. So your prevalence increases over time, and your new infections are increasing over time. If you really, really concentrated your resources to increase testing and increase treatment to really penetrate the MSM population in New York City, you get the aqua line, the bottom line. You have a tremendous success, and in a fairly rapid period of time, you really have a dramatic decrease in the HIV epidemic. So that would make sense, right? And I think a lot of us know this from other models that have been done. If you only focused on testing, you get the red and the green lines here. So obviously, you get a much greater effect if you do treatment as well. But I wanted to save, I think, the most salient piece here, which is the purple line. The purple line is if you do a lot, but you don't reach perfection. And this is really a critically important point as we move forward with implementation, because we can't get everything right at once. And we can't let perfection be the enemy of the good. And here it shows is that if you increase testing, if you increase your testing rate, but you don't get everybody tested, and if you increase your viral suppression rate among MSM, but you don't reach 100%, you actually have a significant impact on HIV incidence, and you actually reach the national strategy goals. So this is really, I think, an important point at the local jurisdiction, because we can be paralyzed by how to change and paralyzed by the desire to do everything right the first time. And this really points out getting some critical parameters and getting that in place and increasing coverage in a high-risk population really makes a difference and can meet the strategy's goals. So given that emphasis on treatment and given the importance of treatment in the approach to HIV, both from a prevention standpoint and a health outcome standpoint, where are we in this country with regard to HIV treatment? And again, I think that many of you are probably very familiar with these data, but it's sobering to look at where we are in the United States. Of people living with HIV in the United States, only 13% have private insurance coverage, nearly a quarter have no coverage at all, and nearly half receive some sort of Medicaid services. And thankfully, because of the Ryan White Care Act, over 500,000 people living with HIV, nearly half of people living with HIV in the United States, receive some sort of Ryan White supported care. And we see that when we look at this map from the AIDSview website, this is looking at rates of persons living with an HIV diagnosis and percent of population without health insurance by county in 2009. Now, there's not a perfect correlation here. There are high rates of lack of insurance in some communities with relatively low rates of HIV. But you can see, particularly in the south, along the southeastern coast, and on the west coast, there are high concentrations of lack of insurance coverage and high rates of HIV. And this really reflects what we see. I think this is directly correlated what we see in terms of HIV-related disparities in healthcare. We have tremendous HIV health outcome disparities. Not only so earlier we talked about the differences and the disparities in HIV incidence. This is now looking at after you've been diagnosed, what are the differences in health outcomes? Time to AIDS and death after an AIDS diagnosis is greater for MSM of color compared to white MSM. There are excess deaths among blacks compared to whites living with HIV. There are life expectancy losses for Latinos living with HIV compared to blacks or whites, and life expectancy losses for women of color compared to white women. And this has all been documented in a robust body of research. But I think that there's hope. And this is the other half of the slide here. This is looking at time to death and time to development of AIDS within a closed healthcare system. This is a study that was published by Kaiser. And what they did here is they looked at Kaiser patients living with HIV, and they looked at time to AIDS and time to death by race ethnicity. And what's remarkable here is even though the Black and Latino patients came into care later, they had a lower CD4 count, and sociodemographically they came from lower socioeconomic neighborhoods. You see here that the health outcomes in terms of time to AIDS there were no differences between time to AIDS diagnosis by race ethnicity. And in terms of death, there was actually a less risk of death among Latino patients, and there was no difference between blacks and whites. So this is a ecologic finding, right? This is not a randomized controlled trial, but it really does suggest that healthcare coverage is a gateway to addressing the HIV disparities that we have demonstrated so robustly in this country, and that the national strategy really brings forward as a priority to addressing. So that brings me towards health equity and what the Affordable Care Act can really do for this country from an HIV perspective. Certainly it's transformative in other ways in terms of transforming health and wellness in this country, and the opportunities are incredibly important. And when we talk about our prevention efforts and our treatment efforts, it's helpful to think about how really big these numbers are, and how the fact that this is the biggest opportunity for generations for us to really shift HIV outcomes and health and wellness outcomes in the United States. And obviously this has been a priority of the administration. So the Affordable Care Act expands coverage to 30 million Americans. This will include tens of thousands of people living with HIV, tens of thousands of people living with HIV. Millions of blacks and Latinos, populations at greatest risk for HIV, and this includes among people of color, those at highest risk for contracting HIV, including Black and Latino gay men and Black and Latino women. The Affordable Care Act will prohibit denials of coverage based on HIV status, so this is a game changer in terms of addressing stigma and discrimination on HIV. I mean, as a provider myself, I've had many conversations with people who don't want to get tested for HIV because they're afraid that they will either lose or not ever be able to get insurance coverage. And already, the Affordable Care Act has affected meaningful change now. Millions have increased prevention service coverage, including HIV testing. For instance, on August 1st, millions of American women, 47 million, again, these numbers are sort of hard to wrap your mind around, but 47 million women had increased coverage to prevention services. Millions of young adults between 18 and 26 have been able to stay or have gained coverage based on their parents' insurance plan. The latest number is 6.6 million young Americans. And when you look at HIV rates among young Americans between the ages of 13 and 29, some of the highest rates of HIV infection. So a direct outcome of the Affordable Care Act in terms of potentially improving health outcomes of people living with HIV. And certainly coverage is necessary, but it's not necessarily sufficient to improve HIV outcomes. And I think that this is something that's critically important as we work with federal partners, with state partners, and at the local level to implement the Affordable Care Act. So we make sure that the promise is realized in terms of these coverage numbers. And as that coverage is realized, that we measure what we do. What gets measured gets monitored. And I think that's really critically important. And again, not to measure everything under the sun, not to spend lots of staff time collecting data for the sake of data collection, but really focusing on the salient outcomes that we think are most important. This is a relatively recent publication that ONAP's commissioned from the Institute of Medicine on monitoring HIV care in the United States, and I know many people in this room provided very important input into this document, but really moving towards our parsimonious, harmonious system that's achievable, sustainable, usable at all levels, and data that can be shared across levels and across jurisdictions to really ensure that 30 years into the epidemic, we're using the most salient data in the most timely way to improve health outcomes and prevention outcomes for people living with HIV. So there are lots of needs as we continue implementation, and really at ONAP, we're really looking forward to working with all of you in this room and other partners as we move forward. Continued collaboration at all levels, as I've talked about, maintaining the flexibility at the local level to implement the strategy, keeping in alignment with the national strategy's principles, but making sure that we maintain that flexibility at the same time. Providing technical assistance to prepare the HIV workforce, and I mean here not just the clinical workforce, but the prevention workforce, the community-based workforce, making sure that there's technical assistance provided to help people prepare for this changing healthcare environment, and a shift from process-oriented to outcome-oriented metrics, as discussed extensively in the Institute of Medicine report. Prioritizing, maximizing the continuum of care, that cascade of care, where we're only at 25% of people virologically suppressed. We need to prioritize. That is a priority. It is a priority. We need to go back to that. When you feel like you're having a hard day at work and you don't know where your guidance is, go back to that cascade. What have you done on that day to do something to increase the percentage of people who are either linked to care, who are virologically suppressed, or who know their HIV status? We need research to determine the best ways to move forward among multiple options. I think the modeling can certainly help with that, and having more research to help guide that is critically important. And support ongoing basic and clinical research so that we're here 30 years into the epidemic with the knowledge that we have now, largely because of contributions of basic and clinical research, and that certainly needs to be continue to be a priority. And that's really how I think that we can finally have the opportunity to recognize the President's vision for the National HIV/AIDS Strategy is that the United States will become a place where new infections are rare. And when they do occur, every person, regardless of age, gender, race, ethnicity, sexual orientation, gender identity, or socioeconomic circumstances will have unfettered access to high-quality, life-extending care free from stigma and discrimination. So I'd just like to acknowledge the many people who have participated in preparing this talk and their leadership, and really look forward to an ongoing conversation with each of you. So thank you very much. Thank you very much.
Dr. Colfax and Dr. Hall and Dr. Sansom for some very thoughtful and exciting presentations. I think we have a few minutes for questions from either the audience here in Atlanta or online. Dr. Shukat.
Yeah, I want to thank everybody for a great set of presentations, and exciting for someone who's not in this world to learn what's going on. I wonder, the United States is not the only place experiencing the HIV epidemic after 30 years. I wonder how much our national strategy is similar to what other countries are doing, or novel and, ahead of its time. Maybe one of you could comment on that.
I think any of us would be happy to talk and answer your question, but perhaps Dr. DeCock would like to do that instead.
Well, thank you. I think what's unique about this is the level of political support and concentrating different minds and different constituencies. I think that's unusual for an industrialized country. We have to remember the American epidemic is by far the worst in the industrialized world. I was impressed with the presentation. I wonder if I may segue to a question, which is, it's impressive and it's encouraging and it's inspirational, but the situation is sobering that, 30 years into this, the cumulative incidence in men who have sex with men, which is replicated in other countries where societies have universal health coverage, very high access to antiretroviral therapy, and very supportive environments, London, Amsterdam, places like that. And yet we haven't touched incidence in gay men. And I just wonder what your reflections are on that.
Thank you. First, I think there's a special time right now, as Dr. Colfax mentioned, which is that there's a an engagement from the scientific perspective as well as the political and community perspective that we want to make the biggest difference possible. The number of new infections in the United States per year has actually decreased remarkably since the mid-1980s, when it was at about 130,000 infections per year, and now it's about 48 to 50,000 infections per year. So there has been a change. The question now is, now that we think we know what we need to do, are we able to do it at the level and the scale and the quality that will make that difference? That does depend on resources, but maybe resources from different places than we've sometimes looked for them. It also depends on a continued will from all sectors of society to be able to implement the changes that are sometimes very difficult to do. But I think the United States now has a vision under both the national strategy as well as among all the federal and community partners to actually try to make that difference. And it would be interesting to reflect back on in about maybe 3 years to see whether we can document that we've been able to move towards that with our monitoring.
I think that it goes back to necessary amounts of question. And I think that's really the question, is if you address these other pieces. And when you ask that question, I think it's a critically important one. I was brought back to the local jurisdiction in San Francisco. Yeah. And you think that one of the things that I had discussion when I had the argument in San Francisco was, and some would argue, that San Francisco, that there's a relatively supportive environment in the product community that has a very high level of HIV. So I think it's a combination, thank you. I think it's a combination of making sure that you have those sorts of supportive environments in place, and then integrating a more comprehensive, holistic, and an approach that you actually can measure. And I think that was the piece that, in my view, sort of helped turn the tide in San Francisco, so that you weren't only allocating resources to MSM programs, but you're actually saying, are those actually effective? Are you reaching the MSM that you most need to reach? And are you monitoring testing rates, viral suppression rates, and so forth?
Yes, just to moderate my rather depressing question. I think San Francisco really is a very important example. And actually, to be fair, also in Europe, there's some examples of modeling that seem to show that if we didn't have antiretroviral therapy at this high access, things would actually be worse. So we are having an impact.
Thank you. I think, John, is there a way to access questions from an online audience as well?
Yes, we have a question from Facebook. How does high-impact prevention help community-based organizations and clinicians address the behavioral health needs, substance abuse and mental health, that intersect with HIV risk and pose obstacles to linkage and to retention in care?
Mm-hmm. Well, it's interesting. I think one of the major kind of intellectual outcomes of the past few years of exploring what we're doing in the HIV epidemic is that some of the dichotomies we've created don't make sense anymore. So, for example, what we used to think of as prevention now incorporates access to treatment. What we used to think of as treatment is prevention. And the ability of that battleground is now actually a family working together. I think that you have that in other areas as well. So the question covered several different areas, but the issue is high-impact prevention is trying to say our responsibility when we focus on reducing infections and essentially trying to reverse the HIV epidemic is to do the best with the resources that we have and to make sure that when the American public asks us, did you make a difference, we can say, we have evidence that hopefully we did make a difference, and that we did the best that we could. So some of the questions, if a lot of different interventions, whether it's with different populations, MSM, drug users, youth, or older Americans, whether it's different kinds of interventions, either in the clinical setting or outside of the clinical setting, and whether it's behaviorally focused interventions like sexual education and condom use, or whether it's other kinds of biomedical interventions, all of those can be combined and assessed using the same kind of metrics. And when we put them together, we'll see how some things come out. But there's certainly areas that question touches on that would meet the requirements of high-impact prevention and should be implemented in the United States right now.
Thank you very much. This question is directed to Jonathan and Stephanie. While the data from San Francisco is very reassuring, what can be said on one hand about the relationship between viral suppression and high-risk behavior, and how is that incorporated into the modeling?
So the question is about viral suppression and high-risk behavior.
How do those two interact in terms of how are persons who have viral suppression, how does that affect their behavior, high-risk behavior, and how do what data are there on that, and how does that transfer to the modeling that you're doing?
Well, it's tough to get good behavior good data on sexual behaviors and high-risk sexual behaviors, but there are some. DHAP does some surveys, the National HIV Behavioral Survey, that asks people about their behaviors, and so we use those data and classified them by risk group to indicate underlying risk behaviors, which we didn't vary much within the model. So the effects of treatment were there despite the behaviors. So that's a simple answer to the question. We did incorporate high-risk behaviors. We didn't do a lot of modification of them in this fairly simple model.
And some preliminary data from a nationally representative survey of men and women with HIV in care indicate that actually people taking antiretroviral therapy have less risk behavior that has been associated with transmission of HIV than those who are not. It's hard to do randomized trials, but there seems to be an indication that as a society there may be changes in sexual behavior over time with the introduction of antiretroviral therapy, regardless of which nation you're looking at. But specifically right now in the U.S., at least we don't see a dramatic increase and potentially even a decrease in risk behavior among people who are taking ART, perhaps because they're engaged in the healthcare system and getting other prevention information while they're taking care of their own health and the health of the people that they love.
I'd like to close our session today by thanking all of our presenters for an outstanding session. Just one brief clarification, that was Dr. Kevin DeCock, Director of the Center for Global Health, who was serving as an impromptu panelist for us, for those of us in on our webcast audience. Please join us 4 weeks from today for a session on explaining the unexplained, or as Dr. Popovic has subtitled it, Dr. House Comes to CDC.